Good evening, everyone, and welcome to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Labor's International Union of North America. I'm Leslie Rattan, and I'm pleased to be moderating our 25-session series, which was developed for individuals that have suffered a concussion, their caregivers, and healthcare providers. And our sessions focus on various aspects of concussion and include an expert speaker presentation for the first half, followed by a question and answer period for the duration. And for those of you that have attended before, you'll know that the sessions are recurring every other week, live on Tuesday evenings from 6 to 7 p.m. Eastern Standard Time. Note as well that you are able to submit questions in advance when you register if you wish to do so. So tonight is our 12th session, and if you did miss any of the previous ones, you can actually find those recordings on the Canadian Concussion Center website. For this evening's session, we would ask that if you have a question, if you would just scroll down to the bottom of the Zoom app and you see a Q&A. So you can enter any questions that you have there, and then we will we'll address those after the talk. If you are having any technical difficulties, you'll also see a chat icon at the bottom. So if you enter any technical questions in there, someone will get back to you to respond. So for this evening's session, I'm really pleased to introduce Dr. Snaiderman, and he's going to be presenting on anxiety, depression, and PTSD before and after concussion. Dr. Snaiderman is an assistant professor in both the Department of Psychiatry and the Department of Medicine at the University of Toronto. He's the founding director of the Neuropsychiatry Clinic, the University Health Network, Toronto Rehab Institute, Brain and Spinal Cord Program, where he has worked for 25 years. He has been involved in the field of physical and neurologic trauma for many years. And as a clinician teacher, he has been involved in training medical students, residents, fellows, and ancillary health professionals, as well as the general public over the last 25 years. He's a member of the exam board and an examiner in psychiatry for the Royal College of Physicians and Surgeons of Canada, and winner of the Ivy Silver Award for Excellence in Mental Health Education given by the University of Toronto. He's also a member of the board of directors and advisory board of several acquired brain injury organizations, initiatives, and programs. And with that, I'll turn it over to Dr. Snaiderman.
Thank you so much, Leslie, for that kind introduction. Can everybody hear me well? I imagine they can. If not, raise your hand or let us know. And I'm going to share my screen now. All right. So the topic today is anxiety/PTSD. And the reason why there's a slash is that PTSD is an anxiety disorder and depression in concussion. And I would like to, as always, thank the organizing committee for inviting me and the technical team for helping me sort through the nightmare it is presenting on Zoom without being too technically dumb and able to see the audience. All right. So I imagine that everybody can see my screen. I'm going to start. Disclosure, as is always the case, I have to disclose whether there are any conflicts of interest. I have no conflict of interest. I have no affiliation with any industry, whether it's pharmaceutical or any other kind. My appointment to the University of Toronto is that of clinician teacher, means that I see patients and I also teach. I'm not a researcher, hence no research was harmed in the making of this presentation. And I have 30 minutes to talk about a really complicated topic, which leads me to think that, But anyway, so the caption says, we'll know more once we do an MRI, but yes, this could be a career-ending injury. Our colleagues in physical medicine, surgery, and other specialties are able to benefit from imaging strategies. Unfortunately, in neuropsychiatry, we don't have that benefit. For the purposes of this presentation and in general, philosophically in my clinic, we like to think that mind and brain are the same. Mind is a function of the brain. That does not make us just a bag of neurochemicals walking, but definitely there's a substrate, the physical aspect of mind and the mental aspect of brain. To prove that, the first hint that brain equals mind comes from way back in 1848 when this handsome gentleman named Phineas Gage was working at a railroad track as a railroad track setter. And the rod he's holding on his left hand is called a tamping rod. They used this to tamp the dynamite cartridges they used to open railway pathways. Unfortunately, when he went down and tamped the dynamite exploded and threw the rod under his cheekbone, up all around, behind his eye, and outside of his skull. Surprisingly, he's the first person that actually survived this type of injury in the 1840s. That's him after the injury, and you can see how his eye got damaged. Now, why is this important? It is important because in 1968, his family physician, or his physician there, Dr. Harlow, described on October 20th, almost to the date, described him as follows. Now, I'm not going to put you through a really long text that I actually took from the original document, but we're going to focus on this thing. This physician described him as having changed in personality. He became indulging at times in the grossest profanity, impatient, obstinate, capricious, vacillating, a child in intellectual capacity and manifestations. And I love this one. He has the animal passions of a strong man. And this is one of the most famous phrases in neuropsychiatry. His friends and acquaintances says that Gage was no longer Gage. So this is the first time when somebody suffered a severe traumatic brain injury, survived it, and underwent a change in personality. So this is the first time they started thinking, what's going on with mind and brain? For the purposes of this conversation, and since I don't know the disciplines of the audience, I'm going to assume that there aren't a lot of health professionals. We divide the brain not just anatomically, but also in their function. So all of the blue, can you see, Leslie, can you tell me you can see my cursor?
Yes, I can.
Thank you.
Yeah.
So the thinking brain, or neocortex, is the area that distinguishes us from other mammals, other animals. This is the high level function. The emotional brain is virtually the animal part of the brain, and the very basic survival type of areas of the brain we can call the reptilian brain, which is a brainstem. Why is this important? Well, it tells us about the psychiatric sequela, meaning what happens after a traumatic brain injury from the mental health perspective. How common a problem is it? So in this study by Brian, highly quoted, 11 years old now, they studied 12 months after brain injury patients, and about a third of them reported a psychiatric disorder. Almost a quarter of them developed a psychiatric disorder that never had before. So these are people that had a head injury and never had any issues with depression or anxiety. Now they had problems. What were the most common ones? Depression, 90% of the sample. It was a very large sample. Generalized anxiety disorder, I will speak about later on, and post-traumatic stress disorder. Surprisingly, agoraphobia, which is the fear of going out, was also there. I'm not going to talk about that one. So how does a brain injury affect mental health? This is an equation, and don't panic. I also suck at physics, but I put this because it makes me look smart, and it actually makes sense once I explain it. So C equals E over R multiplied by 0.5, where C is wave propagation velocity. Think of a tsunami. E is resilience, how strong the tissue is, and R is how dense the tissue. Now, this equation only works in low or medium energy impacts when the brain resonates. So what happens? So this is somebody's MRI slide. So imagine that this guy's skull gets hit and resonate like a bell, hence the term ring your bell. So imagine that the first black line is the first impact and the energy starting to move further down and down and down and down. But as the tissue starts constricting and the space starts narrowing, the energy starts amplifying. So by the time they reach the brainstem, the reptilian brain, it's already passed through the emotional areas. The effect of those waves, those tsunami waves, so to speak, concussive waves, amplifies. Now, why is this particular area important? This is the area that we call the monoaminergic nuclei. And in this area lives all of this. Obviously, this is an exaggeration in size. These are microscopic structures. But these are the cells that produce the neurotransmitters that allow us to function. So this is the part of the brain that works as software, all the chemicals. So some of them you might have heard, like dopamine, noradrenaline, or serotonin. Everybody hears serotonin, or histamine, like antihistamines. So this is the factories for all of these neurotransmitters. So if this area gets damaged, there is no way for those substances to travel through the pontine basal cortical relays, complicated name, but basically what it means, those are the long axons, the long fibers that communicate from the centers of the brain all over to the neocortex, the thinking brain. So if this area was disrupted, clearly there's going to be effects on areas of motion, areas of balance, but also areas of emotional and behavioral control, sleep, appetite, energy, etc. So for example, orexin has been associated with appetite and sleep, dopamine with motivation and energy, attention, noradrenaline with mood regulation, etc. So let's move on to traumatic brain injury and mood syndromes. What is depression? What do people feel with depression? They feel helpless, they feel guilt, they feel shame, lonely, they feel pain, both emotional and physical. They feel hopelessness in serious cases and isolation. And what can cause depression? Well, lots of things, something like this. Certain hockey teams' lack of championship wins. And if you can read what it says, I cry at night, and I'm not gonna say what team it is, you all know which one. So what is the criteria for a major depressive disorder? This is from the DSM-5. This is kind of the Bible, the manual of psychiatry. I'm not gonna go through this, it's too much information. So let's use some magic, get rid of the excessive words and go depressed mood or loss of interest or pleasure in daily activities for more than 2 weeks. Now, everybody can have a really bad week and really bad 2 weeks, but they're still functioning. So the next thing is important. Impaired function, social, occupational, and educational. And they need to have 5 of the next 9 symptoms: depressed mood, weight change, sleep problems, psychomotor agitation, feelings of worthlessness, diminished ability to think, and in severe cases, thoughts of self-suicide. So if we break down this rather tedious slide and we divide it in symptoms, we can say that a major depressive disorder or episode has emotional symptoms such as constant sadness, almost every day. That's important. Feeling of worthlessness or excessive or inappropriate guilt. And this is crucial: suicidal thoughts, intent, and actions. I will talk about that a bit more later. There has to be loss of interest or pleasure in favorite activities. And physical symptoms: low energy. Psychomotor impairment is how well you coordinate, how well you move, how well you think, how fast you think. Aches and pains, insomnia or too much sleep, change in weight, up or down, low to absent sex drive, and change in appetite. Sometimes patients ask me, why do I ask them about their sex drive? And it's important to mention that this is one of the reptilian brain areas. So sleep, appetite, energy, sex drive are all related to that reptilian basic biological function. So it's important to use that as a gauge of general function. Nature is very wise. So when our brains or our bodies are under stress, it shuts down sex drive. And in some women with severe injuries can actually stop completely ovulation and menstruation. What are behavioral symptoms of depression? Restlessness or apathy, irritability, impatience, and aggression. And this is more common in males. We tend to be a bit more, how should I put it, concrete, less in touch with what we feel and how we share it. So instead of perhaps being sad or tearful, we become irritable, impatient, and aggressive. What are the cognitive symptoms? Difficulty making decisions or focusing, very common. Problems paying attention, memory problems, and slow thinking problems. I call it the Costco or Loblaw syndrome. Patient goes to a grocery store and is immediately bombarded with tons of visual information, music, which is not great. Actually makes me feel old when I hear the music I used to like in the 70s and 80s now in supermarkets. But anyway, and they feel overwhelmed and they have to get out. It's too much to process. Now, there are many depressive disorders, but all of them share sadness, guilt, shame, irritability, and suicidality. So the most common one would be major depressive disorder, but you also have people with what used to be called dysthymia or persistent depressive disorder, which is constant low-grade depression. In some women, premenstrual dysphoric disorder used to be called PMS. Substance medication induced depressive disorders. There are some medications that can actually produce depression, and disruptive mood dysregulation disorder. That's more in children. But the one that takes precedent in brain injury would be depressive disorder due to a medical condition, where the medical condition is traumatic brain injury. So what happens after a traumatic brain injury? Well, several studies that are quoted at the bottom estimate that the frequency of traumatic brain injury can be between 6% and 77%. Now, when you see numbers like that, you realize that something's wrong. You cannot have researchers saying only 6% of people get depressed and other groups saying, no, 3/4 of them get depressed. So there are methodological problems in the research, and we're not sure, sorry about that, we're not sure exactly what's going on. Some of the issues are that in the first year post-traumatic brain injury, the frequency is definitely between 1/4 and half of the patients go on to develop depression. And over the lifetime, between 1/4 and 2/3 can develop depression. What are the problems? Some of these studies use different populations in their methodology. So they might use young people versus old people, or people in certain ethnic groups or certain geographic places. They use a variety of research tools and arbitrary cutoffs as to what is depression. Some studies talk about depression as a symptom. The patient feels depressed, as opposed to a disorder. They have depressive disorder. So it's a bit of a mess. One that is quite impressive is a study published in 2002 by Koponen in Finland. If you want to have really good data epidemiologically, you have to go to Scandinavia. These guys were able to follow only 60 patients, but for 30 years, that's unheard of. And they found that over the lifetime, these 60 patients, almost 1/4, more than 1/4, developed depression after brain injury. So what is an issue when it comes to depression? Why some people get depressed? If the patient has a history of mood or anxiety, depression or anxiety disorders, and previous poor social functioning, they were poorly housed, financially restricted, isolated, maybe substance use, maybe comorbid, other medical illnesses, they have a higher rate of depression. The effect of the different risk factors can vary over time, so that initially they might have some problems that are not as serious in terms of affecting depression, and later on they might have others. So psychosocial factors are more relevant in chronic stages. So typically, initially, when somebody has a traumatic brain injury, whether it's a concussion or more severe, everybody rallies around them. They start having lots of support, but over time, they become isolated. They might not be able to work. So the psychosocial factors become more prominent. Alcohol abuse is a significant risk factor for brain injury and brain injury mood disorders. What about the differences between depression after brain injury versus garden variety or regular depression? The symptoms are very similar. As you saw before, they're very similar. However, the physical symptoms, what we call somatic symptoms, fatigue, pain, sleep problems, eating problems, might be related to the brain injury and not necessarily the depression, or might be related to non-brain physical trauma. So if somebody sustained a concussion, but at the same time had whiplash and cannot sleep because of pain on the neck, or a low back pain, or side effects of medications, that is a problem. Now, cognitive symptoms might be related to the traumatic brain injury and not necessarily depression, or vice versa. Depression might be related more to the cognitive symptoms than the brain injury. Irritability, poor frustration tolerance, and apathy are very common after traumatic brain injury and often go unquestioned, unchallenged, or not asked for by clinicians. Another issue that might be common secondary to a brain injury is lack of insight. Insight is the capacity we have to self-monitor, to understand what's going on with us. Now, this is a very sad slide, and I'll navigate you through it. My apologies to the audience for looking at this. This is Statistics Canada in the last census, the last data available on census, which is 2012 to 2016. And it tells us about the number of deaths by cause and the age-specific mortality rate by 100,000 population. So we see that, for example, assaults, homicides, in 2012, 13, 14, 15, 16, an average, or let's say 440 people were killed. Each one of them an absolute tragedy, an unnecessary death. However, it pales when compared to suicide. So in suicide, 3,000, almost 4,000 people die every year. And when it comes to accidents, tenfold, 30 times more people are killed every year in accidents. I checked today the number of people that have died from COVID-19 since the pandemic started, and it's inching towards 30,000. It's 28,000 as of October the 8th. If you start adding up how many people are killed in car accidents, in accidents, and in suicides, COVID pandemic is nothing. And that I realize the significance of what I'm saying, but this is a humongous epidemic and it's not talked about. And it's not talked about because of stigma, which kills. What are the rates and predictors of suicidal ideation? Ideation means the person is thinking about suicide, not necessarily wanting to die. During the first year after traumatic brain injury, and this study by Michael Prang, they studied almost 600 patients with severe to mild TBIs between 01 and 05. They used several strategies, several tools, and 25% reported suicidal ideation. What were the predictors? A prior suicide attempt, history of a mood disorder, in this case bipolar, less than high school education, and the rates of suicide among patients with traumatic brain injury exceeded those found among the general population. Some studies say threefold, other studies say more. So a mood disorder after traumatic brain injury is a serious issue that needs to be investigated, asked about, and talked about from the patient point of view. Now, what about traumatic brain injury and anxiety disorders?
Okay, Peter.
I hope everybody
I think you know what this chat's about. Well, this is never easy, is it? You've been struggling over the past few months. You've let the team down. I mean, surely you must know what they think of you. You're not coping. Say, look, I'm sorry, but it's not working. You see, the bottom line is, you're just not good enough. You are a failure. Just because you have a young family, that's no reason to keep you on. I mean, quite frankly, Peter, you'd think a grown man could look after you.
Pete, hi, sorry about the last minute catch up. So there's this job I want your input on. It's very similar to the one we have just completed, but the timelines are much tighter.
Is it you or anxiety talking?
So apologies for the rather thick Australian accent. There was no way I was going to dub it, but the video is quite telling. And that's the type of gremlin, that's the type of ghost thoughts people get in their heads, and that fit criteria for what we call an anxiety disorder. There are 7, actually more, but we're going to talk about anxiety disorders, and we're going to talk only about two of them due to the time restrictions. One is generalized anxiety disorder. The other one is post-traumatic stress disorder. Now, what is generalized anxiety disorder? This is excessive anxiety and worry occurring more days than not, at least 6 months, about a number of events of activities. It is impossible for the person to control the worry. And when people tell these patients, don't worry about it, just don't worry about it, the answer is, if I could, I would. They really cannot control it. And it has to be associated with 3 physical symptoms, which I'll discuss shortly. What are the cognitive symptoms in generalized anxiety disorder, which we call GAD? These are the typical thoughts that patients express. Something is going to go wrong. Number 1, it's catastrophic thinking. This worry is going to make me nuts. I need to be sure nothing bad is going to happen. So they go to the utmost degree to try to prevent an imaginary catastrophe from happening. Now, what are the physical symptoms? Typical muscle tension, pain, headaches, feeling keyed up or on edge, feeling restless, irritable, and sleep disturbances. More often than not, the patient is exhausted, is able to fall asleep, but then wakes up in the middle of the night within 2 hours, and then starts what we call ruminating, thinking over and over and over about X, Y, or Z problem. What are the behavioral symptoms of generalized anxiety disorder? Avoidance, very common, avoiding of news, newspapers, or anything that makes the person remember the worry. Restricting involvement in activities due to excessive worry, so not traveling if somebody had a car accident, not using a bicycle if somebody had a bicycle accident, etc. And excessive reassurance seeking or over preparing, for example, like a certain presenter that over prepares for a certain presentation on a certain Tuesday on Zoom when he or she cannot see the audience. I've been told. Now, what are the most effective treatments for generalized anxiety? The one that's been the most studied is cognitive behavioral therapy. Unfortunately, I don't have the time to get into the specifics of cognitive behavioral therapy, but what it involves is it challenges the thought and the thinking pattern the patient presents with, and it's based on data. So what is the data you have to worry that your spouse is going to have a terrible accident, or that you are going to be involved in some catastrophe at work? What's the data? What are you basing at? What's your past experience? And make the patient understand the difference between thoughts, feelings, and behaviors. An undervalued but highly effective mode to treat anxiety is exercise. And over the past 2 years, I've been prescribing literally more and more exercise to patients, tons of recourses of exercise. Meditation. The combination of cognitive behavioral therapy and medication is actually the most effective way of treating generalized anxiety disorder. Now, I put medications aside because I am not going to describe any issue with medications in this presentation. Stay tuned for session 2, quick commercial break, November 23rd, this same channel, this same time, in which I will discuss medications for neuropsychiatric issues. Now, motivational interviewing and cognitive behavioral therapy works. What is motivational interviewing? It's 3 sessions in which I try to educate the patient about brain injury. How does it happen? Very much with what I'm doing with you now, and help them understand that this is treatable, that it's been going on for a while, but there are things that can be done. And studies have shown, like this one from Ponsford in Australia too, I think, that CBT and motivational interviewing have better outcomes. Now, cognitive behavioral therapy in brain injury is not a panacea. It works very well, but it has to be dosified, it has to be given to the right person for the right cognition. So it's been studied in a lot of research groups, and this particular study looked at 24 studies with 500 people, And they came to the conclusion that, yeah, CBT is not a panacea. It can be very effective for anger or coping, but will not necessarily generalize for anxiety or depression, except if you use cognitive behavioral therapy specifically for anxiety and depression. So this shows, I hope you can see it, a guy with a snake running after a woman, and the caption says, and for the rest of his life, the young reptile suffered deep emotional scars. I love Gary Larson. It's a shame he stopped doing The Far Side. So we're talking about trauma. Post-traumatic stress disorder. Now, for somebody to develop post-traumatic stress disorder, they have to have a traumatic event. Now, a traumatic event can be anything. So what we're talking about here is something that goes beyond normal human experience. So losing a parent of old age is traumatic, but is consistent with nature. Losing a child in an accident is beyond what's normally expected. Now, the person has to have preserved recall for the traumatic event. They have to remember the event. Why? Because the next thing is reliving of the traumatic event, such as nightmares, flashbacks, which is sudden intrusive thoughts about the incident, or just intrusive thoughts about the event. So they have to be able to remember it. An avoidance of the traumatic situation or the circumstances around the accident or the traumatic event. The patient then goes on to develop what we call heightened arousal and startle responses. They're jumpy, they're easily frightened, they're scared all the time, they're tense, they can't relax. All of these symptoms have a negative effect on mood, typically depression, and cognition. They can't think properly. The thinking slows down, as we saw before. They have problems with attention and memory, and sleep, appetite, energy, and sex drive is disrupted. This has to last at least 1 month, and as always in psychiatry, it has to cause functional decline. If you're still functioning, it's not necessarily a disorder. They have traits of the problem, but not the disorder. Unfortunately, post-traumatic stress disorder in traumatic brain injury is the most studied anxiety disorder. Why do I say unfortunately? I say that because out of the war in Iraq, the United States Army gathered tons of cases of explosion-related mild traumatic brain injuries. So the car would be going on through a mine or some sort of explosive device. The device explodes, creates a concussive wave, as you saw in the graphic that I showed you. The soldier has a mild traumatic brain injury. They're not necessarily severely injured, but then goes on to develop post-traumatic stress disorder. It is challenging to diagnose post-traumatic stress disorder in mild traumatic brain injury. Delay in diagnosis is very common and oftentimes is overdiagnosed. Anterograde, or what we call post-traumatic amnesia, in other words, what can the person remember after the trauma, might be a protective factor. So for example, if somebody is involved in that event, a soldier in a tank goes through a mine, the tank explodes, the soldier is unable to remember anything because they sustained such severe injuries and they cannot recall what happened, that might be protective against post-traumatic stress disorder because they can't recall. I've seen many, many patients involved in, say, car accidents where they are completely unconscious for weeks and they don't remember the accident and they don't go on to develop post-traumatic stress disorder. Hence, the patients that are able to remember what happened are the ones in mild traumatic brain injury or concussion. However, some recent studies show that it can actually happen that the patient might not have the memory of the traumatic event. So the memory systems might not be there. However, the reptilian brain experienced the trauma, and hence there might be more hyperarousal, the tension, the startled responses, and avoidance. And this is a very good slide from McAllister. It shows the interface of post-traumatic stress disorder with persistent post-concussive symptoms. So we have PTSD on my left and persistent post-concussive syndrome on my right on the screen. And if you see the middle, the coexistence of depression and anxiety, insomnia, irritability, anger, trouble concentrating, fatigue, startle response, hyperarousal, people are tense, and avoidance, both of these symptoms, both of these syndromes, illnesses, share the same symptoms. So oftentimes we get patients with post-concussive syndrome that look like PTSD, but have just post-concussive syndrome, and vice versa. Very difficult to diagnose. Brain injuries resulting from biomechanical trauma, that means something physical happened to your body, are often sustained in the midst of events that are psychologically traumatic. So if you were involved in a car accident, and even though you might not have lost consciousness, you still remember the trauma, that's psychologically very scarring. Or even if you didn't have a brain injury, but you lost a leg, that's also very psychologically impactful. It is interesting that neuroanatomically, both traumatic brain injury and post-traumatic stress disorder share the same underlying mechanisms and areas in the brain. So what are the treatment issues? The psychological approaches for PTSD, once again, our friend CBT, cognitive behavioral therapy, and there's one particular form called cognitive processing therapy, which I'll explain in a minute. Neurorehabilitation is very important. Crucial, substance use treatment. I tell the patients I assess that if you are having an issue with alcohol, cannabis, I don't have time to get into the cannabis conundrum, but alcohol, cannabis, cocaine, stimulants, the chances of me successfully treating your mood disorder, your anxiety disorder, your cognitive issues are significantly decreased. And exercise, as I said before, is a fantastic way of helping patients. I'm not going to talk about medication today. I will do so in a couple of weeks, or next month, I mean. So what is cognitive processing therapy? It's a variant of CBT. It has a manual that the therapist has to follow. Unfortunately, there's only one study that I could find that proves some efficacy in traumatic brain injury, because cognitive processing therapy was developed for patients with rape. It means the therapist helps the patient avoid avoidance of the triggers, of what triggers the recall of the bad memory, educate the patient about what PTSD is, be aware of the negative thoughts and feelings, that they are only that, thoughts and feelings. They're not reality, and challenge or question negative thoughts. Let me quickly go into what we call somatic symptom disorder. It is a disorder that is considered to some extent an anxiety disorder, in which the person has quite a lot of focus on physical symptoms such as pain or dizziness or vertigo, weaknesses, olfactory issues that result in major distress and, once again, problems functioning. There are ongoing thoughts about the worry that these symptoms produce that are out of proportion with the seriousness of the symptoms. There's high level of anxiety about health in general or symptoms. There's a lot of time spent and energy worrying about these concerns, and the physical symptoms may or may not be associated with a diagnosis of a medical condition, for example, concussion. So these are people, it's very common, a very funny anecdote. Almost everybody that goes through med school at some point develops some form of this. When I rotated through the cardiology service, every palpitation I felt, I was already ready for the bypass, or any chest pain was, I'm ready to die from a heart attack. When I went through the diabetes service, if I was peeing too much information, I had diabetes. I think the only service that I was safe in was obstetrics. Fortunately, that would have been interesting. So I'm going to show you a very disturbing trauma content ahead. You've been warned. It's a video, it's very short. Hopefully it's not too hard.
Chocolate on my fingers, icing on my lips, sugar, diabetes, and blubber on my hips. I keep the nightlight burning in the kitchen, babe, so I can go downstairs and cruise. I got them Oreo cream sandwich, chocolate covered cream filled with the blue.
So there's the trauma. It's called the Oreo cookies blues. So as you can see, the other two cookies must have been quite traumatized by watching somebody have their head chopped off. So I always say in my talks that it's one brain, but 10 people affected. Depression and anxiety in caregivers are very common. There's always issues with caregiver burnout, a sense of burden from the patient. The patient says things like, my family will be better off without me. There are problems with access to care, physical and access barriers, knowledge of brain and spinal cord injury, and typically concussion patients are complex. There are lots of layers. There's social, financial issues, and medical legal issues at stake. So what happens? A patient sustains a mild brain injury, goes on to develop the physical symptoms we talked about, like headache, dizziness, fatigue. If they go on and on and on, the patient starts developing fear and anxiety. When am I going to get better? This is never going to get better. That produces heightened perceptions like we saw in PTSD. Any symptoms gets amplified. Any problem gets amplified and catastrophized, so to speak, which produces more anxiety and catastrophic thinking, which eventually produces depression, which tends to come with its own headache, dizziness, and fatigue, and creates what we call a feedback loop. So how do we treat? Cognitive behavioral strategies, mindfulness, and interpersonal therapies, as we talked about. It can be done in individual or groups. Social networks are crucial. Family involvement, oftentimes I ask the patients for permission to interview their family members to find out how the patient is functioning, but also to educate them. Structure, consistency, and empathy are crucial. This is Mind Over Mood. It's a fantastic book by Greenberger and Podesky. It's been around for an eternity. It really good self-cognitive behavioral therapy, if you speak the word exists. So treatment, exercise. I name my dog 5 miles so I can tell people I walk 5 miles every day. My next dog is going to be named Miles. Exercise. What's important about exercise? Gradual start as tolerated. So the idea is the moment you have symptoms, stop. But maybe the next time go for a minute longer and see how you feel. And maybe the next time a minute and a half longer. Frequency is more important than type. And the goal is 5 times 30, 5 days a week for 30 minutes. We want you to increase your heart rate, your breathing rate, and sweating so that you know you're doing good workout. And there are excellent beginner videos on YouTube about walking at home and exercising at home that are low impact. And I promise you won't end up looking like Jen Fonda in the 80s. So take home message. Mind is brain, mental health is brain health. Psychiatric disorders are very common after brain injury. Depression is the most common problem, followed by anxiety, but both coexist. Physical and cognitive symptoms after brain injury might be related to depression and or anxiety. The physical symptoms can precipitate mental health problems and vice versa. Depression and anxiety disorders are treatable, but often go undiagnosed. But like anything in life, attitude is everything. Having a positive attitude, not letting the catastrophic thoughts win the battle, is crucial. Just tell it to me straight, dog. Can I still run this weekend? And with that, I thank you for your attention. I'm going to stop sharing my screen. There we go.
Great. Thank you so much. That was excellent.
Thank you.
Very entertaining. So we've got a few questions. So just as a reminder to those of you watching, if you have any questions, please enter them into the Q&A icon below. So we have a question from Francesca. She says, are there any studies that demonstrate a correlation or association between the number of concussions someone has had and proneness to and/or development of a depressive disorder?
That's an excellent question, and the answer is yes. Clearly, the more concussions / mild traumatic brain injuries a person sustains, the more damage is going to be in areas that regulate behavior, emotion, thinking. So we see that is much more common in sustained concussions. The typical example would be hockey players, football players, lately soccer players with the headers that out of necessity or propensity to it, go on to develop injury after injury after injury. And sure enough, we see the rates of cognitive dysfunction, behavioral dysfunction, but also mood problems and mood regulation issues go up.
Great, thank you. Next one, is there a way to differentiate whether grocery store syndrome is due to anxiety or mood problems versus due to vision or vestibular problems?
It's a fantastic question, but a hard answer to give. If the person has visual vestibular issues, but their mood is stable, they're gonna have discomfort. They're gonna have problems focusing, problems balancing. They might feel overwhelmed. But if on top of that, they have depressive symptoms or anxiety, imagine that you're running your computer and you're running Word. And at the same time, you're running YouTube. And at the same time, you are texting or emailing. And at the same time, you realize that you have to do this other homework, and you start overloading your computer. At some point, what's going to happen is going to start slowing down. The performance is going to slow down. It's a bit of a crude analogy, but the same thing happens. So most of my patients with concussion, we have vision and vestibular problems. And if I'm seeing them, means that somebody identified depression or anxiety, so they will have both. Very difficult to differentiate that. One of the ways to differentiate is for the patient to engage in treatment for the mood problem, which is not just medications. It's a bit more complex than just medications. And once the mood improves, ascertain how much of the remnants are visual and vestibular problems. And the opposite direction can also happen. Get tested for vestibular visual dysfunction and see what's there and how much depression might be affecting.
Great, thank you. Joel asks, are there any data or studies linking treatment with EMDR therapy for resolving post-concussion syndrome or persistent symptoms and anxiety?
EMDR, like many forms of therapy, comes in waves. It's almost like the flavor of the year, and then it kind of fades away and then comes back. Same as hyperbaric oxygen, chambers for brain injury, and other forms of therapy. I'm not familiar with any good quality studies that says that EMDR works in post-concussive syndrome when it comes to anxiety and mood problems. There might be studies, but I'm not aware of them. I've had patients go through EMDR, whether it's with a machine that provides differential stimulus or visual. I haven't been impressed. EMDR was originally designed for post-traumatic stress disorder, if I remember correctly. I've not been terribly impressed, but that's just my opinion. Somebody else might have better or more experience with it.
Okay, thank you. Lori asks, when looking at psychiatric disorders in people with brain injuries, do you check for hormonal levels to see what is actually contributing?
Excellent. Yes, I keep on saying excellent question, but they really are good questions. Yes, one of the first things I do is to send the patient for blood work, make sure that there aren't any other potential confounders. Hormonal changes, thyroid, very common, iron deficiency, B12 deficiency, sodium, potassium, calcium, complete blood count. Is a patient suffering from anemia? Is the fatigue related to diabetes? Or perhaps the cholesterol is through the roof and the patient is physically deconditioned. So in psychiatry in general and neuropsychiatry specifically, our first mandate is to rule out non-brain related problems so that we can say with some certainty that this is brain related. Another issue we screen for is sleep. And quite often I send patients for sleep studies, if, well, pre-pandemic, to make sure that there aren't any sleep disorders on top of what the patient presents with that could be contributing to many of the symptoms like sleep apnea that can be almost identical to depression and post-concussive syndrome. So yes,
Great.
that has to be done. Usually a family doctor can do that.
Great question. Jennifer, she says, thank you for the presentation, very informative. What does the early literature say about the impact of the pandemic environment and prevalence of these issues after concussion?
I have a great answer for that one, an answer that for me is liberating, and it takes me out of any dire straits, which means I don't know. And I don't think anybody knows. The literature, the neuropsychiatric literature and the psychiatric literature in general is starting to show that there is serious effects on mental health from the pandemic. I can tell you that the workload has gone through the roof in patients that already have sustained concussions or severe brain injuries, mild traumatic brain injuries, and other disorders, and now are facing all of the uncertainty of COVID and the isolation of COVID. The short answer is, I don't know. I would not be surprised if we have studies in the next year or two showing that there's effect.
Mm-hmm. Great. Woman asks, my question is, can excessive time and energy spent focusing on symptoms, such as always checking for headaches or even anticipating headaches, make my condition worse than actually better?
Well, it's not going to make it better. If you're focusing exclusively on a symptom, could be a thumb ache, a splinter on your thumb, or a headache, your, so to speak, internal radar is going to focus all of its attention into that symptom. And so it's going to make the symptom appear even more serious, more important than what it is. So your reptilian brain is going to kick in and say, danger, danger, danger. And then your anxiety circuitry, the limbic system, is going to kick in and say, yep, this is dangerous. And then your higher cortical areas, the high functioning brain is going to say, yep, this is dangerous. And I still have the headache. And I took 2 Tylenols and it's not going away. It's going to get bad. It's going to get worse. I can't function. I'm going to get fired. Oh my God, my headache just went really bad. So over focusing on a symptom is part of the treatment. It's what we do to try to decrease the emphasis on and desensitize the patient to the symptom as much as possible. Obviously, patients with serious physical issues, it's easy to try to sensitize, but we might not be able to.
Great. Phyllis asks, are panic attacks with sudden noises indicative of PTSD?
No. Panic attacks can, and I apologize sincerely that I didn't have time to talk about panic attacks or panic disorder, which is also common. panic attacks can happen on a myriad of conditions, and it does not necessarily mean you have panic disorder. Panic attacks can happen in PTSD, but a panic attack does not PTSD make. If certain people have a high propensity towards developing panic attacks if they drink too much coffee, or they might have it spontaneously. And that does not necessarily mean they have an anxiety disorder. So no, a sudden panic attack triggered by noises is not indicative of PTSD.
Great, thank you. Tanya asks, is there any data or benefit to treatment with mushrooms or MDMA?
Okay, I knew that question was going to come about. Lots of research into the potential benefits of hallucinogens or psychoactive medications or drugs. None that I know about MDMA, which is an amphetamine compound. Lysergic acid is the real name of LSD. Psilocybin is a compound in mushrooms. There are studies happening for mental health with microscopic doses of these compounds. So ketamine, psilocybin, lysergic acid, LSD. These are microscopic, tiny, tiny doses under controlled circumstances in a lab. We cannot yet generalize that these studies are going to show benefit in brain injury. These are studies for depression and anxiety in the non-neurologically injured patients, as far as I'm concerned. Now, there are some studies that are indicating benefit, however, way too early. If you go to a party and you eat a shroom and expect that your PTSD or anxiety is going to get better, I have news for you. You're going to have a trip, and after you get down from the trip, you're going to have worse anxiety and worse depression. Same with MDMA, Special K, LSD, cocaine, ecstasy. Any overstimulation of the brain leaves the brain drained, and I'm going to super simplify it, leaves the brain drained of neurotransmitters that we talked about. Because you get to hallucinate because there's a massive release of dopamine, for example. And that causes afterwards a state of depression, a state of anxiety, a state of lethargy, and then people are more tempted to redo the trip to try to get the boost. But after several, the brain says, sorry, I throw in the towel, I give up. This is not working. So no, as I said before, I tell patients very honestly, if you're using any psychoactive substance recreationally, I need to know, and you need to know that what you're using might not allow me to help you get rid of your symptoms.
Great.
That's a long
Thank
answer
you.
for a short question.
Yeah, no, that was great. Okay, I'm conscious of time. Let's do one last question. Denise asks, after a severe brain injury, I am curious about the future likelihood for things like dementia.
All right. So I always get into trouble with this question. It always comes out and I always get in trouble. The group here at UHN is very involved in researching this particular question. And Leslie, you're part of the group. So maybe I should pass it on to you. But there is an association potentially between severe traumatic brain injury and dementia later on. Now, and again, correct me if I'm wrong, Leslie, because you might be more aware of the latest research in this. To the best of my knowledge, we're not sure that this is a certainty, that every single patient with severe traumatic brain injury will go on to develop dementia. And there are many layers to it. So is the patient with a severe traumatic brain injury a smoker or hypertension, high blood pressure, a diabetic, no exercise, a smoker, or a very strong family history of dementia? What type of dementia are we talking about? Are we talking Alzheimer's type of dementia? Are we talking other types of dementia? Are the patients suffering from mood disorders that can mimic dementia? Is the patient 91 or is the patient 60? So lots of questions that I'm sure are being worked on, and I don't want to spend too much time on it. But initial research says there's some association. Now, association is not necessarily cause. Something that is associated with another thing doesn't mean that one causes the other. Another very long, convoluted response to a straightforward
I
question.
think that was a great response. Well, I think that brings us to the end of tonight's session. So I'd just like to thank you again, Dr. Snaiderman, for an excellent presentation and getting through all those questions. So thank you everyone for attending. As always, you'll receive a short survey via email. So if you have a minute or two, we always welcome your feedback and any suggestions that you might have. And we will be back here in 2 weeks on Tuesday, October the 26th at 6 p.m. And we're going to have Dr. Paul Rinaldi, and he's going to be talking about what vision therapy and what vision specialists. So thanks very much. Have a great evening.
Thank you so much.